Let's talk a little bit about what mental health, or what as we call it, behavioral health, is like in primary care. We've talked about the needs in primary care, the way behavioral health or mental health or substance abuse or health behavior needs are brought to primary care by all sorts of folks. But we haven't talked about how programs get set up to deal with them, to connect a behavioral health person to a behavioral health clinician, let's call them. Behavioral health clinicians being psychologists, clinical social workers, mental health counselors, marriage and family therapists, mostly. A psychiatrist is a behavioral health clinician, there's no doubt about that, but they tend to be because they are also have MDs, we tend to think about them on the medical side, and because there are so few of them available and they get higher salaries, let's face it, so they're more expensive. People don't use them, or most primary care practices don't use them as the person who does the counseling, the teaching, all of the work that the behavioral health clinician might do. They tend to use them as consultants, and as consultants around prescribing for the primary care doctors and nurse practitioners and physician's assistants. So you will see psychiatrists in primary care, and they're very valuable. It's really reassuring to the doctors, the primary care doctors, to have a psychiatrist that they can call or talk to help them get prescribing right when things get complicated. But let's go back to the other folks who are more the counselor type people in primary care. So you would think that if you just put a psychologist or a clinical social worker or one of the other counselors there in primary care, that you'd be able to have patients go see them, and that would work great. It's a bit more complicated. So there are some common categories around the relationship between medical people and behavioral health people. And so let me just tell you the names of some of them and what they are. So one of them is coordinated care. And coordinated care means that there's a program, but it's set in two sites at least. So the medical site does the medical part of it, and the mental health site does the mental health part of it. You think we already have that because we have medical places and mental health places? No, we don't. Mostly we don't. And that's because they're not coordinated. They mostly don't talk to each other, or they talk to each other on a very infrequent basis. So a coordinated care site would be one where the relationship to exchange information about a patient is already set up. The patients know that if you are a patient at Johnson & Jones primary care practice and you need behavioral health, that we have a relationship with Smith and Bailey Mental Health Center, that we work together, we share information. And that sharing information is really important. It's particularly important around prescribing, because the psychiatrist at the mental health center is likely to prescribe, and the medical people, of course, are going to prescribe, and they often don't have a record of what the other is prescribing, so they have to go by what the patient tells them, and what the patient tells them is, I'm going to make up a number because I don't know exactly, but let's say it's more than half the time wrong. They leave something out, they misunderstand medications, so the doctors just go ahead and do their job and prescribe, but it puts the patient at risk. So one of the things that has to be shared when you have a coordinated program is the information about prescribing. There's also information about what the person's problems or difficulties are. I mean, someone who has diabetes has a certain kinds of challenges. You know, they have to watch their diet, they have to, they're at risk for bad things that can happen over time to their bodies unless they manage their diabetes well. And if the mental health person is trying to help the patient manage their life better and be better at coping with what they have to face, the mental health person has to know about the diabetes. Or if the patient says to the mental health person, I think I'm just not going to worry about drinking as much. I used to just keep it down to 1 drink a day, but now, I just like it better when I have 4 or 5, and so I'm going to do that. The mental health person, if they know about the diabetes, wants to also share that with the physician, because the physician might be in a much better position to say, that drinking that you're doing is going to make your diabetes worse. Even though the mental health person, if they said, it's a bad idea to have 4 drinks a day, it may not have nearly the impact. And so they need to exchange information about what they're doing with the person and what their goals are and what the list of problems are. So coordinated care, when it can be done, is a very good thing, and it's way better than what we normally have. It's hard to do because it takes a lot of administrative work, and sometimes it takes a lot of work with the different practices, particularly the mental health folks, because they're very concerned about not breaking confidentiality. Well, actually, the medical people are just as concerned about not breaking confidentiality. But the difference is, in mental health, the confidentiality is between the patient and the therapist. In medical world, the confidentiality is between the patient and their health team. And so the health team talks with each other because there's so many different roles in the medical world. So that difference sometimes makes it hard to get a plan for sharing information ironed out, although it can be done. So coordinated care, that would be a good thing. The next thing is co-located care. That's where the behavioral health clinicians are in the same practice with the doctors. That has a big impact on how many people can get services. Turns out that if a doctor is working with a patient and discovers that they're depressed, and they suggest to the patient, you really might want to go to the mental health center. They do good work over there, and I think they could help you with your depression. The highest likelihood of what's going to happen next is the patient is going to say, yes, doctor, that's okay. And they're not going to go. Because, one, it's hard to say no to your doctor. It's hard to say, nah, I'm not doing that. What are you, nuts? I'm not doing that. But on the other hand, people don't want to go to a different kind of treatment in a different kind of place that they don't know and that they're nervous about. And besides, they don't want to be defined as someone who has a mental illness. And so somewhere above 70% of the people in primary care wouldn't accept a referral if they got it, which means essentially they don't have access to care. I mean, if you tell me, you have access, I'm going to let you go skydiving. It's really cool. You're going to love it. I would still say, no, I don't have access because there's no way. I'm not going. So unless it's something that someone might do, you can't really say they have access to it. So they won't go. If you bring that same service into the primary care site so that the doctor can say, as part of our team, we have Mary Jones, our clinical social worker. She works with us. We share information. And I think she would be very helpful to you in this time when you seem to be depressed. The chance of somebody accepting that referral goes way up. So now a lot of people get access. When you bring the behavioral health person into primary care, even if they're just there, I mean, when we say co-located, it means in the same space. But we're thinking that there's sort of two different services. There's the mental health part and there's the medical part. And they refer. So the doctor refers you to Mary Jones, the clinical social worker. Like I say, the access still goes up. They will tend to refer mostly on mental health issues, sometimes substance abuse, but those, just those kinds of issues, not more broadly. And I'll tell you in a minute why referring more broadly is a good thing. And the separateness of the services means that often there's not a lot of information that's shared right at the time. So they share an electronic medical record. So Mary Jones writes in the medical record and the doctor writes in the medical record, and they see what each other has put in there. And that's really helpful. Now they know all of the problems that each one is dealing with. They know all the medications that are involved. That's really helpful. But it still has some challenges. It's a little harder to make the referrals happen. There are a lot of people in primary care who don't think of themselves as having a behavioral health or mental health issue. And that definition of, I think you have depression, they're not going to like it. They don't feel comfortable with that. So for those people, they still may not go over and work with Mary Jones. On the other hand, if you have integrated care, that's the next step up, it's easier to get that to happen. Integrated care is where the mental health or behavioral health clinician is available to be part of the care at any time. The doctor will go get that person, or will page them, or nowadays people mostly don't use pagers anymore. They just text. But we'll text Mary Jones and say, can you come to exam room 3? And Mary Jones can come. And they do what they call a warm handoff. A warm handoff is where the doctor introduces Mary Jones to the patient as while the patient is still in care, while they just came to see the doctor. And so now you have all three of them together. And just like you would introduce one friend to another, you say, this is Mary Jones. She works on the team. She's somebody who can help you with the stresses you've been talking about. So now the patient sees the doctor and Mary Jones together. They see that this is a team, that she works with the doctor, and the patient is much more likely to be willing to work with Mary Jones. Sometimes there'll be a little bit of talking there. That means the doctor often will have 2 or even 3 exam rooms that they're using. And so they're working with the patient in exam room 1, and patients are being set up in exam room 2 or exam room 3. And so the doctor will go on to exam room 2 and start working with that patient. And Mary Jones will just sit with the person in exam room 1 for 15 minutes or so. And we'll find out a little bit more about what's going on, maybe do some brief teaching or some suggestions. You know, often for people who have never thought about behavioral kinds of ideas, teaching someone, for instance, who has trouble sleeping at night, there are little exercises you can teach them that will help them put themselves to sleep, which can make a big difference to their feelings and their health and their mood. So it'll be a fairly small kind of interaction, fairly short, but it can make a big difference because you're getting to people essentially earlier in the development of problems. You're getting to them while they're first talking about it with their doctor, rather than 2 or 3 or 4 years later when it's gotten so serious that they have to go to a mental health center. So now you're, because you're so much earlier in the process, first of all, people get better a lot faster. When I moved my practice from an outpatient mental health site to a primary care site, the average number of visits that I saw people, and I worked very short number of visits. I did brief therapy, dropped from 6 to 3, just before I changed anything that I was doing, just because now we're earlier in the process. And so people get better, and less intervention makes a difference. That's one of the things that's really fun about this kind of work. So in integration, it feels like one team. In co-location, it feels like there are 2 treatments in the same place. In integration, it feels like there's one treatment with a medical aspect to it and a behavioral health aspect to it. And that kind of treatment engages patients better, and you can work on the more subtle kinds of problems. So, for instance, I was brought in one day to talk with a man who the doctor says he just won't accept any medication. He has these really significant medical problems, but when I suggest medication, he acts like I didn't say anything. He just ignores me. And so I went in, we sat together, his wife was there, we had an interview, and because I only tell you about the interviews that went well, it went well, and he decided he would accept some medication and he would take the doctor's suggestion. So I think I contributed a lot that day. I never saw him in therapy. I never met him again, except to say hello in the waiting room. So that kind of brief consultation or brief intervention is possible when it's integrated care in a way that really doesn't happen when it's co-located care. And this kind of work, this integrated primary care, as we call it, or sometimes it's called behavioral health integration, is happening all over the country now. Oregon has a Medicaid law that mandates integrated care for serving Medicaid patients in Oregon. Massachusetts has had special programs to integrate care into to serve Medicaid folks. Texas has a big program. Washington State has a big program. In Alaska, there are a number of programs. And the government is all in on integrated care. I don't mean the government like the presidency. I mean the government like the health services that the government provides, like the VA or the uniformed health services. So, there's a major health service in the Air Force and Army and Navy. All of them have their own health services. And the federally qualified health centers, which are paid for by the government and serve low-income patients all over the country, the uninsured patients, the folks who have difficulty getting care really in the rest of the system. So all of those are committed to integrating behavioral health into primary care. And that means that we're working hard to try and develop a workforce to do this. I mean, it's actually, one of my, a person I spoke to, a friend of mine who's at the Health and Resources Services Administration in Washington, said it's a crisis. We have a workforce crisis. And what they mean is they can't find enough psychologists, social workers, mental health counselors, and marriage and family therapists who have been trained to work in primary care and who are comfortable and interested in working in primary care to meet the need. The other thing that's happening is that as integrated care becomes more common, in other words, as people begin to be able to expect that they would get behavioral health services, or as doctors begin to expect that their practice can provide behavioral health services, the other members of the healthcare team start to have little roles in serving patients. It becomes part of what we do in primary care. So, for instance, there are medical assistants, the people who take you from the waiting room and bring you back to the exam room and take your blood pressure and weigh you and ask you some questions about how you're doing, the medical history questions, what your current problems are and so forth, and sort of set up the meeting, the care you're going to have with your doctor. Well, those folks some of them are getting involved in making calls to people who are on the list of patients who are depressed in the practice. And it's been shown that it really helps to check in on people, see how they're doing. If they had medication, are they taking that medication? If they had medication, did they have side effects? If they didn't have medication, how are they feeling? Do they need to come in? Can we just sort of have a little set of questions over the phone to see how your depression is doing? Did it get better or worse since we last spoke? All of those ways that a practice outreaches to its patients helps people keep working on accepting care and making their health better. If people feel like if somebody cares about me, I can care more about myself. And so that role of a medical assistant who makes calls, or a care manager who's often a nurse, sometimes a social worker, who makes calls and outreaches to people. People who, there's people we call health coaches in primary care, some places who do trying to help people be more active in losing weight or getting exercise or whatever they need to do. All of those people on the team need support in being better at the behavioral aspect of their work. They're not doing behavioral health in the sense of therapeutic work, but they are doing work that needs knowledge, wisdom, that's behavioral. And so when you have a seasoned and talented behavioral health clinician, they become a resource to all these other folks, so that everybody's skills at doing behavioral health get better. So nationally, what we're finding is that as integrated care spreads, the behavioral aspect of a number of roles in primary care also spreads. And we'll talk more about that and what that might mean for you in your training, or in the training that you choose at another module. But for now, why don't we stop here, and we'll talk more if you go to the next module. Thank you very much.